femme, elle a kiffé. Elle m'a dit, ça change.
Our webinar. So on behalf of all the countries that are endemic for onchocerciasis, I would like to welcome you to this first activity of the GON. The GON is the Global Onchocerciasis Network for Elimination. That is a new alliance, a new coalition that is being created by all of us, the global onchocerciasis community, in order to accelerate and facilitate the elimination of onchocerciasis with the spirit and the aim of the new NTD roadmap. So these webinars are going to be conducted periodically with the idea of featuring one country at a time and giving the opportunity to this country to share with all of us the progress that they have made in eliminating onchocerciasis, how are they adapting their strategies to the new NTD roadmap, and how we all can support them in accelerating progress, how we can work with them to make things easier, to have better collaboration, to have more cross-border dialogue, to have in reality a better partnership in order to achieve our common goal. So today is really our first activity, our first webinar, and therefore I really would like to have your feedback in what we can consider a pilot. This day is really a pilot on how these webinars will work. So after the webinar or during the webinar, please feel free to provide feedback on how we can do things better to make sure that we utilize the time of these webinars to really learn from one another, to share experiences, and to help each other to achieve the NTD roadmap, with a particular focus in onchocerciasis, but with the spirit really of collaboration across diseases and and mutual support. For that, I am going to ask my colleague Nadia to project the agenda for the day. These webinars are going to be very practical. We are not going to do rounds of introductions. We are going to go straight to the point to make them quick. And we are going today to talk about Tanzania, a country that we have so much to learn from. They have such a wonderful experience. And we are going to start by just reviewing the progress, no? What has been the country progress towards the NTD roadmap. Dr. Clara Jones, the National Onchocerciasis Focal Point for Tanzania, and Professor Rory Post, the chair of the Tanzanian Onco-Elimination Expert Committee, are going to talk to us during 45 minutes. They requested to have quite a significant amount of time so that they could really explain well what are their achievements, their challenges, the way forward, how we can work together with them. We are going to follow with comments from some panelists, mainly focus on cross-border issues in collaboration, how we can collaborate with the bordering countries. So we have invited Dr. Victor Bukumi from Burundi, Dr. Laston Itsima from Malawi, and Dr. Henis Sitoe from Mozambique to discuss some important cross-border issues. And we will continue with listening from the experience from Uganda on vector interventions by Dr. David Ogutu. And he will also share with us about the LISA protocol that they have been using. But at the very end of our webinar, we are going to have questions and answers from the audience. So please feel free to utilize the feature in the Zoom to ask your questions. What would you like us to address? So we will be addressing those questions at the very end of the webinar. And we will conclude with some wrap up and next steps by the chair of the Tanzania National Onco-Elimination Committees, Professor Rory Post. So without delay, I am going to pass the floor to my friend, Dr. Clara Jones, to be the very first one on Break the Ice and lead the first webinar of GON. Thank you so much, Clara, for being with us. We are all clapping for you.
Thank you very much, Dr. Maria, for the very good introduction and a good talk on, and also the initiative and the efforts in ensuring that this, Hello. As I was saying, I would like to thank you, Dr. Maria, for the efforts she put in organizing this network. And as the first presenter, as she mentioned that this is going to be more like a first webinar ever, I'm going to take you through the experience of Tanzania, the country progress toward NTD 2030 roadmap targets for onchocerciasis. And we have done this. We worked together with Professor Rolly Post to put this presentation together. So I'll be doing the first part of the presentation, and Professor Rolly will do the second part. Next, please. So as I mentioned earlier, the outline of this presentation, the presentation is divided in two sections, where I'll do a talk on the onchocerciasis status in Tanzania, looking at the background of onchocerciasis in the country, the LF status in onco-endemic and bordering districts, national onco strategy in Tanzania, and then we'll look at the ivermectin treatment coverage, and also we'll look at the cross-border issues, and finally the key achievements, challenges, and way forward. And after this first section, Professor Rolly Post, the chairperson for the Tanzania Onchocerciasis Elimination Expert Advisory Committee, will talk about the committee and its achievement and how it works in the country. Next, please. So the efforts to control onchocerciasis in Tanzania goes back as far as 1990s, when the first mapping was conducted. And this was done in the selected suspected communities or villages. And this led to the first community-based ivermectin MJ treatment or administration in selected villages in 1994. Thereafter, in 1997, with the support from the APOC, the country program, adopted the CDTA approach, where selected villages were treated. Again, the selected villages were those which were found to be positive with infection during the basic mapping, started the MDA. And with the support again from APOC, the country conducted mapping of onchocerciasis by nodule palpation at site level from 1996 to 2012, when the mapping was completed. And this mapping indicated that 28 districts out of 184 districts in the country were found to be endemic with onchocerciasis. Later on in 2009, the country launched an integrated NTD program, where after that launch, ivermectin and albendazole for onco and LF were provided as one package. And now this was done at the district level. And so all the areas which were found to be hypo and meso-endemic in those communities at district level got the advantage of being treated. And so all the 28 districts which were found to be, which were endemic to LF, which were endemic to onchocerciasis, were also co-endemic to LF. And so they all received one package of ivermectin for both onco and LF. And as from 2015, the country changed the protocol from, changed the approach from control of onchocerciasis to elimination, as it was put by the WHO roadmap that onco was supposed to be eliminated by 2025. Next, please. So currently, in the current onco transmission zone in the country, as I mentioned earlier, we have 28 district councils, which are endemic, and these councils are found across 7 regions. And these 28 districts has been clustered across 8 transmission zones. And there we have Tanga, which is in the north, which have 5 districts. We have Morogoro, which has 2 districts. We have Kilosa with 2 districts. We have Mahenge with 2 districts, Ruvuma with 8 districts, Tukuyu 4 districts, Tunduru 1 district, and we have newly, which has not yet been defined, focus known as Mufindi Njombe, which used to have 2, but we are going to add 1. It was recommended that the newly found area with transmission, if we finish the surveys in there, would also be added to this focus, the newly found focus, newly found transmission area known as Njombe TC. Next, please. The vectors in Tanzania, we have 2 main vectors and 2 species where we have Simulium damnosum complex as well as Simulium nivei. And with Simulium damnosum, we have areas where we have several vector cytospecies as well as non-vector cytospecies. With nivei, with nivei group, we have the Simulium woodi. Next, please. The distribution of the vectors in Tanzania, if you look on the map on your left side, it shows how these vectors are distributed, where from the we mainly have damnosum, Simulium damnosum as the main vector. However, in Tanga focus, which have in Tanga focus, that's where you find the Simulium nivei. And in Mahenge focus, we have both Simulium nivei and damnosum, though the mainly dominating species there is the nivei in this focus in Mahenge, which is purple on the map. There are few nivei and a lot of Simulium damnosum. Next, please. So now looking at the ALF status in onco-endemic and bordering districts. As I've mentioned earlier, that all the areas which were endemic with onco during the integration, they were also found to be endemic with ALF. And also the bordering districts were also endemic with ALF. However, after the intervention and the conduction of this transmission assessment survey, all endemic area, all the areas which were endemic to onco are no longer receiving MDA against ALF, as they have passed the transmission assessment surveys at different stages. But also the neighboring councils, which were endemic with ALF, has passed transmission assessment survey at different stages. And only one council, if you can see at the map, the one with red, known as Pangani, is the only one which is going on with ALF MDA. And we have one council here, which is non-ALF endemic, and it was also not endemic to onco. Therefore, this council is ivermectin naive. The rest have received ivermectin at some point during the ALF MDAs. Next, please. So now, how do we implement the national onco strategy in the country? First of all, this strategy, the implementation of onchocercasis program in the country is guided by several documents, where we are guided by the Tanzania Health Strategic Plan 5 as the main document for the health sector, the Health Sector Strategic Plan 5. And then we are also guided by the NTD Strategic Master Plan, which was launched this year in January. It is a 2021-2026 document, the master plan. But also we are guided by the NTD Sustainability Plan 2021-2026, which was also launched in January, and the WHO NTD Roadmap of 2021-2030. And our goal as a nation is to eliminate onchocercasis by interruption of transmission as a public health problem by 2030. And this has been stipulated in the NTD Strategic Plan as well as the Sustainability Plan. And also, as we have attained the 100 geographical coverage in all endemic area, our goal is to sustain this until we have eliminated transmission. And also another goal is to sustain the 80% therapeutic coverage of the at-risk population. Now, in the course of implementation, this program is implemented in a cascade manner where we have the central level, which is at the Ministry of Health, and then we have the regional level, the council level, and then down to the community level and frontline health workers. At the central level, mainly the central level has the following responsibility. One is advocacy, which include resource mobilization, and then we train the TOTs, and so we train the regional level, and then we ensure there is enough supplies and medicine for the implementation of the interventions. But also at the central level, we do conduct M&E. And so at the regional level, they also have the responsibility of conducting advocacy, supportive supervision, as well as M&E. And at council level, they conduct social mobilization, training of frontline health workers and teachers who are involved in mass drug administration, and also distribution of medicine, conducting of M&E. And when you go down to the community level, they are the one who does the drug distribution, and also the frontline health workers trains the CDD. So in general, the implementation of the onco strategy is embedded in the health system, where we work directly from the national level up to the community level. Next, please. So the approach which we are doing to eliminate onchocerciasis for now in the country is the mass drug administration. This is the only approach we are applying for now. And we have been doing this in all the 28 districts. And as of 2022, all the 28 districts were still providing ivermectin for onco. And some areas have received between 8 to 20 rounds of annual MDA. And we have one council, as I mentioned earlier when I was talking about the transmission zones, which is going to start MDA in 2023. And so from 2023, we will have 29 districts distributing ivermectin for onco. And for the 2022, we had the approximately the targeted population from the, actually we used the projection before we could have the actual from the census. The projection indicated that we had at least around 8 million people at risk in the 29 districts where we'll be implementing MDA next year. And from 2018, actually, during the course of this implementation, way back from 2009, we had been implementing annual MDA. But from 2018, we switched from 9 councils, switched from annual to twice MDA to accelerate the elimination process. So these were from 2 different forecasts. One forecast has 5 councils, and the other one has 4 councils. And from the and so we had 9 councils distributing twice MDA, and 19 councils still providing MDA for onco. And these ones which are providing once MDA has also received between 10 to 20 rounds of MDA. And some have done that even for more than 20 rounds. And the reported coverage from these districts ranges between 70 to 92, as we'll see later in the reports. Next, please. So the trends now of treatment coverage over years. We have the reports from the 1997 when it was when MDA was distributed in selected communities up until 2021 when we are doing the distribution at district level. So the trend shows that there have been an increase in the coverage. And the latest one was in 2021, where we had the coverage of 85%. In 2020, we didn't do the MDA because of the issues with COVID-19. So we couldn't manage to do the MDA in 2020. So this is the trend of implementing coverage over the years from 1997 to 2021. Next, please. So the plans, the MDA plan for the year 2023, we are going to do MDA in 25 districts and we are going to administer the medicine for onco. And why 25 districts? We have 4 districts in Tukuyu Focus, which are under the research. It is under the CDC, where they are trying to look at the threshold for interruption of transmission. So the area is in the research. So this year we won't be doing MDA in these 4 councils. So the plan for 2023 will be doing it in 25 districts. And the targeted population in these 25 districts is about 5 million, where we'll have 14 councils doing biannual MDA, and the population in those who will be doing biannual MDA is 2.9 million. And the one which will be doing, the one which will be doing biannual is 2.9 million. And the one which will be doing annual MDA will be 2.4 million. And we are doing this at the level of the district. As of now, with all the councils which require MDA, plan to conduct MDA in 2023, except for the 4 districts in Tukuyu Focus, which are under the research. Next, please. So in the course of implementation, we have been conducting impact assessments in these areas where, as I mentioned earlier, the baseline, which was conducted in 1997 and completed in 2012 through nodal palpation, recorded the prevalence ranging between 7 to 95% in adults. And then that's when that was when we also started implementing MDA with the support from APOC. From there, we conducted the monitoring survey from 2004 to 2010 through microfilaria skin snip. And these were purposive sampling of villages across Focus with individuals aged 16 and above. And this monitoring survey indicated that the prevalence from these areas ranged between 2.5 to 9.8. Later on, there are the surveys which were conducted, the phase 1A and phase 1B surveys from 2009 to 2012 through microfilaria skin snip. Again, they recorded the prevalence which ranged between 0.03 to 3%. And as we have been observing the advancement in technology, also the diagnostic tool has been changing. So from 2012, we stopped using microfilaria skin snip. So the surveys which were conducted from 2015 to 2018, we used OV16 RDT. And again, these recorded the prevalence ranging from 0 to 5.8, and only one council from Ruvuma recorded the highest prevalence of 22.4. And later on, we conducted the onco-elimination mapping in 2021-2022, which is still going on using the OV16 RDT. And I will be talking about this more in the next slide, where we conducted ITAS in 8 councils. ITAS was the Integrated Transmission Assessment Survey, where it was done together with the Transmission Assessment Survey for LF in 8 councils. And this was conducted in 25 villages per district. 5 purposely selected and 20 were randomly selected. And we collected sample from adults aged 20 years and above. We had the results ranging from 0 to 10.2%, and now we are analyzing the sample which were collected from children aged between 6 and 9 before making the decision whether these cancers are going to go for MDA or they can be recorded as non-endemic areas. And also we conducted the pre-stop MDA surveys in 2022, where we conducted in two foci. One focus passed, therefore we are going to conduct a first ever full stop MDA in Tunduru, which is one focus, but this is only in one district. And the other one where we conducted the pre-stop MDA is going back to doing MDA, and then we'll consider doing the pre-stop in the near future. And apart from these serological surveys which has been conducted, we have not been able to do the entomological survey except in Tukuyu Focus, which I just mentioned earlier. And this is, Tukuyu Focus is under the research, so it has a comprehensive surveys going on there. Next, please. So, as I said earlier, that I was going to talk a little bit more on this onchocerciasis elimination mapping. We are still providing MDA on endemic district, but as we're moving toward the target of eliminating onchocerciasis by 2030, there are several hypoendemic communities or districts which were suspected that are not receiving MDA because they were not initially targeted or have stopped ivermectin and albendazole MDA as they reach the criteria for stopping LFMDA. So the program conducted a desk review and gathered evidence and of all those areas which were suspected, we came out with 15 councils which had the criteria for conducting onco-elimination mapping, and the criteria were either they are bordering the endemic district or they have features, similar features that support livelihood of black flies, if they have fast running water and rivers. So of these 15 councils, 8 had already conducted the ITAS, and we are about to finalize the analysis of the samples, and so we'll make a decision through the Tanzania Onchocerciasis Elimination Committee, which will decide whether we are going for MDA or not. And the remaining 7 councils, we are going to conduct onco-elimination mapping in those areas. Next, please. And so this is the Tanzania onchocerciasis flag as of 2022. Actually, as a program, we have a tool which is used by the Tanzania Onchocerciasis Elimination Committee to make a decision. It's slightly different from the color codes used by the ESPN, but the colors are defined. Hello? The colors are defined according to the activities which is going to happen, which is going to be conducted in that focus. So as of 2022, this is how the flag is looking like, where we have, our flag has 7 colors. The white areas represent non-endemic areas based on either onco-elimination mapping and REMO. So looking at the map, all areas which are white are considered non-endemic. And then we have the gray color, which indicates that transmission status is not known. And in those areas, we are supposed to conduct onco-elimination mapping. So on the map, if you can see well, we have 7 councils where there are 7 districts where we'll be conducting onco-elimination mapping in this financial year. And also we have the red. This indicates that transmission is still ongoing, and this area are still on MDA for onco. And then we have the yellow, which indicates that the suspected transmissions, the suspicion that transmission has been suppressed. And the activity there is to conduct a pre-stop MDA survey and also continue with MDA until there is evidence that onchocerciasis has been interrupted. And also we have the light green, where transmission, this indicates that transmission is suspected to be interrupted, and this area we are conducting stop MDA survey. And we have the dark green, where transmission is interrupted, and we are supposed to conduct post-transmission surveillance, and the blue, where transmission is eliminated. So as per the 2022 progress, this is how the flag looks like. Next, please. Now, the progress of onchocerciasis elimination in relation to the 2030 roadmap, as I just mentioned in the previous slide, looking at the map, so far we have 148 districts out of 184, which are non-endemic, and we have 7 districts where transmission status is not known, and we're going to conduct onco-elimination mapping. We have 19 districts with transmission ongoing, and we are still doing MD in those areas. And the population which are in red zone are above 4 million. And we have the yellow. We have 5 councils which are going to conduct pre-stop MDA, where we suspect that transmission has been suppressed based on the monitoring survey results which we have. And we have the 5 councils which are going to conduct stop MDA surveys. Of these, 4 councils are those ones which are under the research, and 1 is Tunduru. So we are expecting this year to have stop MDA surveys in 5 councils. And we don't have any councils which are under transmission interrupted, as well as none is in the blue. So this is the country's status as far as the 2030 roadmap is concerned. And we're looking forward to having at least interrupted transmission into focus with at least 1.2 million saved from the transmission. Next, please. And this one is talking on the cross-border issues. So as we can look at, as far as onchocerciasis transmission zones are concerned, we do have cross-border issues with 3 countries where we have Malawi, Mozambique, and Burundi, as shown in the map. Next, please. So with the border, when you look at the border between Tanzania and Malawi, the border between Tanzania and Malawi is formed by the River Songwe. And as the research done earlier, it was concluded with reference to what Maega et al. Published and the other literature review which we did recently. It was suggested either on either direction between Malawi and Tanzania because of this the river which forms the border between these 2 countries. So the possibility of transmission, there's no evidence of cross-border transmission between Malawi and Tanzania. Next, please. And with Tanzania and Mozambique, the REMO, which was conducted in 1997, indicated that Mtwara was non-endemic. And WHO APO categorization indicated that Mtwara was not suitable for onchocerciasis. However, Newala DC and TC, which is in Mtwara, the border between Tanzania and Mozambique, borders Mueda in Mozambique. And the satellite images suggested that there's possibility of breeding site. And we conducted an entomological survey in this area in 2022, and it indicated that there was no evidence of oncotransmission regardless of these satellite images. Therefore, in this area as well, there is no, the likelihood that there is transmission is really small. Next, please. And this is the border between Burundi and Tanzania. And this area between Burundi and Tanzania, it shows that there are likelihood of cross-border transmission, since we have Kigoma, where previously APOC reported that there are some positive in this area. And also in the other side in Burundi, there is transmission there. So in this area, we are going to conduct onco-elimination mapping just to make sure that there is no trans-border transmission. Next, please. So the conclusion with these cross-border issues as far as our program is concerned is that between Tanzania and Malawi, we found out there was no potential for cross-border transmission. Between Tanzania and Mozambique, no potential for cross-border transmission. But between Tanzania and Burundi, there could be potential for border transmission, cross-border transmission. That's why in this Tanzania-Burundi, in the part where it borders Burundi in Kigoma, we're planning to conduct an onco-elimination mapping survey there. Next, please. Now, what have been the key achievements since the inception to where we are right now? On the left side, you see the baseline map and the baseline surveys, where it was indicated that the prevalence ranged between 10 to 95%. So as a program, we have attained 100% MDA geographical coverage, where all areas which are known to be endemic are covered with master data administration. And another significant achievement is that there has been a significant decrease of infection from 95 up to 95% to 0.6% in 27 endemic council, except one which reported 22.4% in the recent monitoring surveys. And also we have had 9 districts which are on biannual MDA since 2018 to accelerate transmission of interruption. And of these 9 districts, 5 are going to conduct pre-stop MDA this year. And we have 4 councils which have reached the threshold for stopping MDA. And this is in Tukuyu Focus, where we are also going to conduct a full stop MDA together with another district from Tunduru Focus. So our plans for the next year is to implement MDA in 25 councils, to conduct MDA, full stop MDA in 1 council, Tunduru Focus, as well as the 4 councils which are under the research. And also we are going to conduct pre-stop MDA in 5 districts in Tanga Focus. And we're going to conduct onco-elimination mapping in 5 districts. And these districts are not ivermectin naive. Therefore, we are going to test children between the age of 6 and 9. Next, please. Now, the challenges which the program is facing and critical action. First and foremost, as we are in the area of conducting these stop and pre-stop MDAs, we have limited lab capacity for serological analysis, staff, reagents, technical know-how with regard to ELISA and PCR. And we also have a challenge in CDD turnover due to lack of incentive and motivation. We also have limited entomological funding, and we have had to reach the target community due to geographical barriers. And the status of addressing these gaps, for the first gap, which is limited lab capacity for serological analysis, The program is working in partnering with research and academic institutes for implementation research like CDC, NIMRI, and Muhimbili University of Health and Allied Sciences. And for the CDD, we are looking at the need to review the CDTI approach, given the dynamicity in the villages where previously would consider it as people volunteering. Now there are slight changes due to the changes in lifestyles. And for limited entomological funding, we are looking at advocacy and see how we can attract more funding in this area so that we can combine both the MDA together with the entomological interventions. And with hard to reach and targeted communities due to geographical barriers, we're looking at how we can intensify community sensitization for point drug collection instead of the door-to-door distribution. Next, please. Finally, what now is the country's expectation from this network? We are looking to have an access to a big pool of experts, especially in areas of entomology and lab technologists, so that you can have more information which will lead to making evidence-based decision. And also we're looking forward at establishing more partnership with expert research, academic institutions, as well as donors, and also learning from other programs and how they are doing it, and also what steps they are following for achieving the 2030 goals. And this marks the end. Next, please. This marks the end of the first part of the presentation. I would like to welcome Professor Rowley to continue with the second part of the presentation. Back to you, Maria.
Thank you so much, Clara. And it was fantastic. And I welcome Professor Rory to continue. Just be aware that you only have 7 minutes left for the part of the presentation. So let's try to make it concise, so we can go to the discussion as well. But it was really, really informative. Thank you, Clara. Back to you, Professor Rory. Please keep it concise.
Okay, can you hear me? Can you all hear me?
Yes, we can.
Okay, good. So, I'm talking about the function of the TOAC, the Tanzania Onchocerciasis Elimination Expert Advisory Committee. So, okay, I want to start my video, although you'll be all looking at the screen. So, anyway, TOAC is the Ministry of Health Advisory Committee. So it doesn't make decisions itself, it advises the Ministry of Health, who then make the decision as to whether they want to take any notice of our advice. It was established in a enthusiasm in 2016 after WHO recommendation to move to elimination. It comprises the following different types of members. Those appointed by the Permanent Secretary of the Ministry of Health. There's 22 voting members. There's invitees and observers, both of whom are non-voting. So the invitees are the WHO representative, observers, implementing partners, donors, etc. There's representatives from the endemic districts who attend the committee meetings. They're non-voting, and of course the Secretariat as well from the Ministry of Health, non-voting. The committee is multidisciplinary, aiming to have members with a wide range of technical skills and experience relevant to onchocerciasis, like medical background, parasitology, entomology, etc. And remember, the members are chosen at the discretion of the Permanent Ministry of Health. Next slide, please. Right, these are the TOAC meetings and key milestones. As I say, it was started in 2016 with enthusiasm with the change to elimination of transmission. Well, I won't go through these various meetings and key milestones because we're limited in time. I first attended and was chairman in 2021, and so I've been the chairman for 2 years. Okay, next slide, please. Right, these are the roles and responsibilities of the TOAC. I want to list all of these. These are what have been given to us by the Ministry of Health. It's quite wide-ranging, and I think I will go through them. So it's to advise the roles and responsibilities. Number one, advise the Ministry of Health on onchocerciasis elimination strategies, including the review and, as needed, establishment of specific measurable disease-specific goals. Provide written recommendations for the programme annual plan of action at least annually. Review and monitor the National Programme for Onchocerciasis Elimination in line with the NTD master plan goals and targets and the WHO 2030 roadmap. To review reports on onchocerciasis programmatic activities, data analyses, monitoring and evaluation activities, with scientific presentations of national and international research relevant to onchocerciasis to advise the NTD control program and the Ministry of Health. To provide guidance on onchocerciasis disease monitoring and evaluation to assess the impact of the program through impact surveys. To provide strategic guidance, including sustainability of the program and activities in collaboration with partners and stakeholders. To gather lessons learned from other countries and assist the program in adopting them. To revise the program's goals and indicators to match the current needs while considering WHO 2030 roadmap targets. And to identify local program operational research needs and mobilize partners to address them. Notice that the roles and responsibilities as given to the program do not specifically mention other NTDs, although, as you've heard, LF has passed TAS in all the onco-endemic areas. All right, next slide, please. Okay, so if we look at the NTD roadmap, we'll find that it says, number one, to stop mass drug administration by ivermectin, at least one focus in 34 countries. There's somebody talking. To stop MDA in more than 50% of the population in at least 16 countries, and to stop MDA in the entire endemic population of at least 12 countries. We consider Tanzania to be on track to be one of the 16 countries to stop MDA in more than 50% of the population, and is aiming to be one of the 12 countries to stop MDA in the entire population. But that will depend upon the results of current onchocerciasis elimination mapping and keeping MDA coverage up, and the hard to reach areas you heard about before. And it will probably be necessary to introduce biannual MDA in all endemic areas. Next slide, please. So we were specifically asked to address the questions, how does TOAC and the program in Tanzania work with other stakeholders? Well, the main stakeholders are represented on TOAC, where they take part in planning, implementation and monitoring of activities, implementation research for decision making, and to provide financial support and medical supplies. In the past, other stakeholders have contacted the program directly, not through the TOAC, but directly. For example, the current multi-country Stop MDA Threshold research project being carried out in Tanga. And in that case, TOAC's only role is to assess the research plans to ensure that they do not interfere with Tanzania's progress towards elimination. We don't expect that they will interfere with that, but it's the job of TOAC to consider that. TOAC may act to introduce relevant outside stakeholders to the programme when this would help to solve particular challenges. Next slide, please. We were also asked to specifically address the question of how TOAC and the elimination programme identifies and addresses challenges. What's the process for that? Well, primarily this happens at the annual TOAC meetings. The programme makes separate presentations on each of the transmission zones, and for each of them reports a brief history of MDA along with previous year's reported MDA coverage, and any coverage survey results. It reports training and retraining of CDDs, the results from any surveys, such as impact surveys, pre-stop MDA surveys, etc., and other activities, such as vector prospections. The programme will then also present its proposed plan for the following year and the programme's own assessment of the challenges which it's come across and is facing. The programme will also report to TOAC on other issues, for example, onchocerciasis elimination mapping. TOAC aims to have sufficient expertise amongst its members, many of whom also sit on other NOECs, and also other participants to assess the challenges and recommend and then it recommends how to address these challenges. If TOAC needs specialist help, it can contact other outside experts. Next slide, please. Okay, this is a review of some of the issues which have been identified and are still ongoing. TOAC is reviewing the implementation of the strategy for 2 times a year MDA, and the implementation of so far is that there's been 4 years of 2 times MDA in 2 foci, and there's a proposal to have an additional 2 foci to that in 2023. But TOAC will also be considering whether there would be advantages going to 2 times per year in all foci. The gaps are to do with, in this process, are to do with funding cycle alignment and fast turnaround. There's also an issue of CDD turnover and motivation. Second issue, or recommendation, is listed here, is to enhance MDA planning and monitoring. And the implementation so far has been to a district engagement, improved district engagement with annual health plans the annual health plans include NTD elimination. There's a dedicated NDT coordinator, and there's a reporting system, a sustainability plan, which has been produced. Problem there is inadequate resources. Next slide, please. There's a recommendation that, well, there is some issues concerning infection monitoring in humans and vectors, but current endemicity status has been established in line with new WHO guidelines, but the problems there with this area of infection monitoring of humans and vectors, the problems are limited lab capacity for serological analysis, and there's limited entomological funding available for the entomological monitoring parts. Now, it is and that's also the case. The limited entomology funding is also affecting the onchocerciasis elimination mapping. You will have noticed on one of the earlier slides that the non-endemic areas were identified by a mixture of onchocerciasis elimination mapping and the old REMO studies. But many of these areas will need to be reassessed using exclusion mapping, but there's a problem of entomological expertise to do that. Okay, next slide, please. That's the end. Thank you very much.
Thank you so much, Professor Rory. That was really, really clear, and it was really very, very informative. So I am going to invite all our participants to actually send the feedback on the template that we have used for this presentation, since we will be using the same template for all the different webinars that we are going to be doing. So please feel free to send your feedback on whether you think this template could be improved, if there is information you think it was missing, or you would like to see the information presented in a different way. And please do that by email. You can email myself and also Nadia Rosendahl, that is the person that is acting currently as the Secretariat of GON, supporting the entire network to really have activities and progress. So feel free to email both of us. Without delay, I'm going to pass to the next agenda item, that is to share experiences from the cross borders. So I'm going to invite Dr. Victor, Dr. Laston, and Dr. Hennis from Burundi, Malawi, and Mozambique to share their remarks from the perspective of the cross-border relationships. The floor is yours if you are ready. I hope so.
Thank you very much, Maria. Can I start?
Absolutely, go for it.
Okay. My name is Alasto Stima, coordinating on gas control program in Malawi. So for Malawi, we are bordered by Mozambique to the southwest and southeast, then Tanzania in the northern part. So, and then to the northern western part is Zambia. So basically the cross-border issues that Malawi is experiencing, there are a few of them. The first one is the unknown situation in the districts of Mozambique bordering Malawi, because those districts are the ones where treatment is going on. So we, as of now, we don't know the onco situation in the district of Mozambique bordering Malawi. Then the other issue, another cross-border issue is there are no harmonized activities taking place between the two countries. I'm referring to Malawi and Mozambique, especially in the assessments. If at all assessment is known, then if assessment is conducted, then we can know what next, the actions to be taken. Then the other issue is about little or no cross-border collaboration taking place between these two countries. We are talking about Mozambique because it's where the districts which are bordering Mozambique are the ones where we are conducting treatment. So we would love that there should be so much collaboration in terms of cross-border. So to answer the second question on how to come together to address cross-border issues, I think there is a need for platform. There is a need for platform whereby all the countries have to come together so that they can discuss the cross-border issues and the way forward for them for the betterment of the countries, as we are talking of as we are progressing towards elimination, and we are talking of elimination by 2030, roadmap for the WHO. So there is need for platform for the countries to come together to discuss these cross-border issues. So I think basically it's what I can talk about in terms of the cross-border issues as far as Malawi is concerned. Thank you so much, Maria.
Thank you so much, Laston. That's very helpful. I am going to give the floor to our colleague from Burundi or Mozambique. If they are online, please feel free to take the floor, and please use your language, because we have simultaneous interpretation into French and Portuguese. So feel free to speak in Portuguese or yeah, in Portuguese or in French. Yeah.
Yes, good evening, everybody. Me, I'm Dr. Victor Buchumi from Burundi. I'm the coordinator of the program in charge of NTD in Burundi. Let's continue in French because
Oui, merci. C'est mieux. On a la
yes,
traduction simultanée. So I am inviting all the English speakers to please click on interpretation. There is simultaneous translation. Thank you.
oui, vous avez suggéré à ce qu'on puisse parler à propos de la collaboration transfrontalière entre le Burundi et la Tanzanie dans la lutte contre l'onchocercose. Ici, je signalerai, comme on l'a déjà présenté de la part de la Tanzanie, nous avons une frontière commune à l'est du Burundi entre la Tanzanie et le Burundi. Et dans cette frontière, il y a une partie qui est sous traitement, c'est la province de Rutana et une partie de Makamba, dans le cadre de TIDC, traitement par ivermectine sous directive communautaire. La région est sous traitement depuis 2006, donc ça fait plus de 15 ans que la zone est sous traitement. Et à côté, on avait identifié des districts hypo-endémiques qui n'ont jamais connu de traitement jusqu'à présent. Et nous sommes en train de préparer une évaluation, une prospection pour l'actualisation des gîtes larvaires en vue de tendre vers la cartographie d'élimination de l'onco dans tout le pays et spécialement dans cette région. Très bientôt, nous allons entamer cette prospection pour actualisation de gîtes larvaires dans tout le pays, y compris la région frontalière avec la Tanzanie. Donc, comme aussi la région de Kigoma, peut y avoir des cas de l'onco. Ce serait une très grande opportunité si on pouvait travailler concomitamment avec la Tanzanie pour pouvoir mener une surveillance conjointe dans cette région frontalière avec notre voisin, la Tanzanie. Il n'y a pas donc d'activité qui est prévue ou qui sont prévues dans ce cadre. Nous n'avons pas de plan de surveillance transfrontalière avec la Tanzanie. Pratiquement, il n'y a eu aucune activité conjointe relative à la surveillance transfrontalière entre le Burundi et la Tanzanie. Donc, nous aurons besoin d'un appui technique et financier pour pouvoir débuter les activités de surveillance transfrontalière. Mais de notre côté, nous sommes avec nos partenaires, notamment SPN et Endfound et CBM. On va bientôt initier les enquêtes pour l'élimination, d'abord pour l'actualisation des gîtes larvaires par la prospection, et puis nous allons nous préparer pour une enquête pré-arrêt de traitement par l'ivermectine dans les zones actuellement sous traitement depuis plus de 15 ans. Et si les résultats seraient en faveur d'un arrêt de traitement, on envisage aussi de conduire une évaluation épidémiologique dans tout le pays pour être sûr si la maladie est totalement contrôlée avant de procéder à l'élimination. C'est ça que je peux signifier pour le moment par rapport au Burundi. Je vous remercie.
Merci infiniment, docteur Buchumi. Et est-ce que le docteur, si Dr. Sitoe, de Moçambique, es que você lá? Você pode falar de la situação das fronteiras entre Moçambique e Tanzânia, se você está conectado? Você pode também falar em português?
Boa tarde.
Boa tarde, obrigada.
Boa tarde a todos. Obrigado pela oportunidade. Não sei se conseguem me ouvir.
Sim, você pode continuar. Sim. Estamos
Sim.
Yes.
Em relação a Moçambique, nós ficamos desde 2001 até então com a confirmação de que Moçambique é hipoendêmico a oncocercose. E pelo fato de ser coendêmico com filarias linfáticas, houve necessidade de se iniciar as campanhas de tratamento massivo com recurso à ivermectina e albendazol. E pelo fato de o país ter percebido que havia necessidade de conhecer a nova realidade de Moçambique em relação ao conservador, em 2019 foi conduzido um estudo na região centro e norte, com enfoque para os distritos que fazem fronteira com Malawi e Tanzânia. Esse estudo tinha duas vertentes. A pesquisa humana, através de coleta de amostras de sangue para testagem laboratorial, usando o OV16, mas também foi feita uma análise para avaliar a presença do vetor transmissor da oncocercose nos mesmos distritos a quem me referia. Estou a falar do distrito de Lago, Sanga e Mecanhela Geniais. Esses três distritos fazem fronteira com Malawi, assim como com a Tanzânia. Nos distritos de Lago e Sanga, foi possível identificar a presença de larvas da mosca negra e para Sanga todos os rios foram visitados e tiveram resultado positivo. Em relação à pesquisa em humanos, também nesses dois distritos foi verificada a circulação, ou seja, foram encontrados casos positivos ao teste rápido. Inclusive também na província da Zambésia, nos distritos de Milange e Morumbala, também foram encontrados larvas da mosca negra, assim como houveram resultados positivos de alguns indivíduos que residem naquela área. Em relação a aspectos de coordenação transfronteiriça, bom, nós só temos a realçar o fato de a SATSES, que foi o parceiro que financiou esse estudo a que me referia de 2019, também criou condições para que Moçambique tivesse algum intercâmbio com Moçambique, aliás, com Malawi, nas regiões transfronteiriças da província de Zambésia, particularmente em Milange e em Mulumbo. E neste momento estamos a trabalhar com a componente entomológica para a identificação dos prováveis rios que possam ser potenciais para a existência da mosca negra. E, bom, em relação à capacidade técnica e laboratorial, dizer que Moçambique tem um mínimo de condições para o efeito, porém carece de condições financeiras para dar seguimento a essas atividades. Como puderam entender, o país é vasto, tem 61 distritos, mas esse estudo só foi conduzido em 7 distritos apenas. Então, há necessidade de continuar um mapeamento completo de todo o país para não continuarmos a depender dos resultados do remo que foi realizado em 2001, que estava baseado apenas em observação clínica, a palpação de nódulo. Também a dizer que, se calhar, há necessidade de desenvolver melhor intercâmbio entre os países vizinhos que já relataram a endemicidade desta doença. Obrigado.
Muito obrigada, Dr. Sikoi. Então, now we are going to pass to Uganda, that will like to share with us some experience on vector interventions with ground larvicidin. Dr. Ogutu, if you are ready, please take the floor.
Thank you very much. Vector control for control and elimination of onchocerciasis was one of the earliest interventions taken actually in 1940s, 1950s, before Uganda became independent. So this was done by the British. They started application of DDT on the Nile. They achieved at the source of the Nile to eliminate the Similium terminosum there, but they failed totally in the lower side of the river where many tributaries were joining the Nile. So that was a good experience. So when the program was formed in 1993, the vector control was resort. So we started mapping of the potential rivers to isolate the foci together with mass treatment with ivermectin. So then later in 2007, when the National Onchocerciasis Elimination Policy was launched, entomology was preferred as another intervention to support semi-annual mass treatment. So vector control was intensified with several entomological activities. The beginning of it was river prospections, conducting entomological surveys to identify rivers which were supporting breeding of vectors, identifying different vector species which were transmitting, and then delineating the transmission zones in Uganda, which we refer to as foci. So we then, after doing that, started river dosing with a bait. That is Temephos. Vector monitoring was started. Now, when we started river dosing, it was important to do vector monitoring because as you dose, you want to monitor how are the vectors reducing in the population. So we established several monitoring sites in the different foci to monitor whether we're achieving the intended purpose. So with areas where Similium nevi was the vector, that was much of the western part of Uganda and the Mount Elgon, we started to target vector elimination because the vector there is weak. It is in phoretic association with the crops and the rivers were small. So river dosing was done in those foci and the vector was totally eliminated. In Uganda, we eliminated Similium nevi in 6 foci. And that was followed by complete elimination of onchocerciasis transmission. For the areas where Simulum daminosum is the vector, we targeted vector control. So vector control to ensure that as we treat, the population of vectors able to transmit to other people is reduced. So we started also ground larviciding, that is now in the northern part of the country. And so far, so good. We achieved reduction of the population, the vector population. And in 2018, we shifted from larviciding using a bait to a new method, physical method, which is community health, self-help. It is called slash and clear. The communities affected by fly bites and on-call transmission are mobilized to slash in areas of the river, sections of the rivers, which are supporting breeding of the flies near to them. And that is working very well. And so far, the vector population has reduced in these areas. So in summary, we have made tremendous achievements, eliminating Simulum nevi in 6 foci. We are now suspecting to have interrupted transmission of onchocerciasis in S. daminosum foci. What remains to be done is to address the cross-border transmission issues with the DRC and with South Sudan. But we have started that. Actually, we are now joint interventions and monitoring, both epidemiologically and entomologically, are taking place. So far, so good. Out of the 17 transmission zones, the foci, we have stopped interventions in 15. We have stopped intervention in 15, and we have eliminated onchocerciasis. In the next 2 to 3 years, we are going to stop interventions and go to post-treatment surveillance. Now, for OV16, in Uganda, we use OV16 monitoring for to monitor exposure to Onchocerca virulus in the foci, and also we use it in post-treatment surveillance to ascertain whether the interruption of transmission has been sustained. So we do this by testing children below 10 years. Our results from OV16 have provided evidence to the Ugandan onchocerciasis elimination advisory committee to guide the country, and we hope that the next 2 years, Uganda is there, complete interruption of transmission in all the foci. Thank you very much.
Fantastic. Thank you so much for sharing those experiences, and I'm sure they will inspire many of other countries in the audience. So we have 10 minutes left, and the chat has been actually very active, and there are a number of questions there that could be interesting to address. So I'm going to invite Clara and Rory, to go through the chat quickly and scan which questions you think are more relevant for you to react to, and also to react to the comments of Mozambique, Uganda, Malawi, and Burundi in the 10 minutes that we have left. And while you do that, while you scan through the chat, I'm going to also use the opportunity to thank all the partners that have been working very hard supporting Tanzania. I can see them present in the audience, many of them: USAID, RTI, Act East, and also the MECTIS and Donation Program from the Task Force for Global Health, for their active collaboration and partnership, without which they would have never been able to go as far as they are today, really, and with this successful program in Tanzania. So thank you for your partnership, for your support, and for your donations. And I pass the floor to Clara to react as you wish, because as I said, there is so many comments there that I don't want to filter them for you. I prefer if you choose the ones you think are more relevant. And please, let's stay on time. Thank you. You have 10 minutes.
Thank you very much, Dr. Maria. Thank you very much, Tanzania, the neighboring country, Mozambique, Malawi, Uganda, for the presentation. As the country are also ready to work with you all in these cross-border preparation issues. So I'm going to go direct to some of these comments in the chat, though I may not be able to address all of them. There was a question from Thomas Usnach asking, where does the lab support fall in this structure? As we are moving toward we are conducting stop MJ surveys, we would need a lot of entomologists in the field, so we wish to have a training on how to do the entomology, as well as all of the processing for the PCR and the related issues, because we have really few entomologists in the country, so we would wish to have that training. And also to train we are working with NIMRI, but we have really shortened staff there, so we need to have more lab scientists recruited in this field as we are moving toward conducting the stop MDS, which will require intensive labor. And there was a question on the coverage, which was asking on the 1972 if it was epidemiological or programmatic coverage. This is the coverage I presented was from the at-risk population, so this for the whole entire total population. And for the question where it was asking for using RDT on all fresh blood or eluded DBS, we use eluded DBS, and our implementation unit is a district, and the rest, Professor Rolly can help to respond to them. Thank you, Maria.
Thank you so much. Professor Rory, do you have any other comments to the many questions or reactions from the other countries and colleagues?
Yeah, okay. I've been, now this is, it's echoing back on me. I won't. Can you hear me? Can you hear me? No.
A little bit. If you can repeat.
Can you hear me?
I think it was breaking.
Yeah. Can you hear me? What's happening is I've got an echo of myself.
Okay, so try to maybe mute the computer so that you don't hear so not mute the microphone, but the speakers, so you don't hear yourself even if you have the echo, so that you can speak.
Try doing that, okay. Can you hear me now?
Yes, I can, but you cannot.
Can you hear me now? No, I don't think that's working.
No, it's working. It's that you cannot hear us because you just muted yourself.
Yeah, but could you hear me when right. Let's try that again. Can you hear me? Put your hands up. Yes, fingers. It appears that you can hear me. All right. I've got there's a lot of questions and it's difficult to know which ones to answer. A lot of them are to do with, shall we say, strategic issues, which were already being dealt with by the program and the elimination committee, the elimination advisory committee. But somebody asked us a question about cytospecies. So I will make one comment on that. Vector cytospecies are known in most of the areas, and there's a mixture of cytospecies in the country, some of which some of which are vectors and some of which are not vectors, some of which are important vectors and some of them which are less important. And it would be useful to know the distribution of those vector cytospecies in the potentially cross-border areas. Okay, somebody asked a question about whether there was data for the in the areas which would either support or was used for going from once to twice a year. Yes, there was, as you will have noticed. It's been taking quite a long time in some areas to reduce the prevalence significantly. Although prevalence in all areas is going down, there's been good results but it has been going down rather slowly, and that was the rationale for going to 2 times per annum, and that's the rationale for thinking about some of the new areas going to 2 times per annum. Obviously, what one is also considering is at the same time is what the level of MDA, what the percentage of coverage is. There was a question about, several questions about the transmission zones. How were they defined and are they isolated? The answer is that the definition of the transmission zones is been difficult. And so what's been taken has been districts and council areas have been taken as to be the operational units, and the transmission zones have been defined according to their borders. One of the rationales behind that has been that in the absence of very detailed mapping, it's a safe process to go through. It's a safe decision to make, to say, well, okay, we may in some cases be treating areas where there may not be endemicity, but that's better than, because of extending out to the whole of the council area, but that's better than not treating those areas if they were endemic. So the council areas and the districts have been taken as the operational units, and their borders have been taken to define the borders of the transmission zones. That means that although in some cases it's clear that that areas are isolated because they've got different vectors, it's not clear in most cases as to whether the extent to which they may be isolated from each other. Okay, how are we doing for time? Oh, it says according to my watch, we've only got 1 minute left. So I'll close with my comments on the questions. There's been very few I've been able to answer.
Thank you so much, Rory. That was really helpful. I hope we can continue this very important conversation offline now that we have seen how much richness in sharing the experiences and discussing them can bring to us. And I really invite you to share these further questions and comments offline through emails and through WhatsApp or the way you think, or we can organize a follow-up webinar. I want to use this minute left to let you know that we will have another, the second webinar of GONE, hopefully on the 15th December, this time talking about Niger. a country that will be hopefully the first country in the African region to present the dossier of for submission for verification of elimination of onchocerciasis. So we are trying to set that one up for the 15th December, and I would like to invite you all to participate on that one as well. And also in December, we have the meeting of the onchocerciasis technical subgroup called OTS, from the 19th December to the 21st December. And I would like to invite you all as well to participate as observers and be part of the discussions and hear what is going to be a very interesting agenda. And with that, I thank you so much for being part of this first webinar. And I invite you one more time to say webinars as efficient as possible. Thank you so much for your attention. And with that, stay well and talk to you all very soon. Bye.
Obrigado.
Bye.
Amanhã. Amanhã da manhã.
Bye. Até amanhã.
Priori.
Aí.